At Next drug is atropine. So atropine blocks the acetylcholine effect, or parasympathetic. Atropine blocks the effect of acetylcholine at parasympathetic sites in smooth muscle, thus increasing cardiac output. So atropine is a parasympatholytic. Actually, atropine worsens MI. And why we don't give atropine less than 0.6 mg? Because if we give 0.5 or lower, it will cause paradoxical bradycardia. What are the pharmacokinetics of atropine? Its onset is 15 to 30 minutes. In IM, if you give IV, it is immediate onset. It's hepatic metabolism, and half-life is 2.1 to 3.9 hours. It is given 0.04 mg per kg or 1 mg every 3 to 5 minutes, maximum 3 mg. Atropine is a first-line therapy in the treatment of symptomatic bradycardia. So if your bradycardia is asymptomatic, means there is no hasya, you may or may not use atropine. Atropine is no longer recommended for the treatment of asystole or pulseless electrical activity. It may precipitate or worsen the myocardial ischemia in patient with coronary artery disease, ACS, CHF, tachycardia and hypertension. IV giving IV dose less than 0.5 mg or slow injection are associated with paradoxical brady. So you need to give atropine only bolus fast. The most common adverse effect of atropine are just your anticholinergic effect, which were blind as a bat and all. So it causes tachycardia, constipation, xerostomia, that is dry mouth, blurred vision and photophobia, because it's going to dilate your pupils. Next is adenosine. Adenosine is an AV nodal blocker. It slows the conduction through the AV node, interrupting re-entry pathways through the AV node, and restores normal sinus rhythm for patient in SVT. So in supraventricular tachycardia, when there is a nodal re-entry pathway or some accessory re-entry pathway, it slows the AV node, thus aborting the SVT. It is used for the treatment of PSVT and VT with or without re-entry pathways. After failure of vagal maneuvers. It is ineffective for conversion of atrial fibrillation, flutter or VT. So it is used only in PSVT and not in AF, flutter or VT. Common side effects of adenosine. We will not use adenosine in asthma patients. Its side effects are chest pain or pressure, headache, feeling of doom, flushing, nausea, bronchospasm, AF can occur. Next is magnesium sulfate. Magnesium sulfate acts via inhibiting calcium current that cause pathological early after depolarization and causing cardiac dyssynchrony. So magnesium sulfate blocks calcium. It slows SA node activity, prolongs myocardial conduction time, IV magnesium sulfate has a rapid onset of action indicated in torsades de pointes polymorphic VT associated with a prolonged QT interval. It can also be used in cardiac arrest, which was associated with torsades de pointes and prolonged QT. So it is used in torsades de pointes, polymorphic VT and prolonged QT. 1 to 2 grams of IV is diluted in NS or D5 and given rapid. Side effects are vasodilation, flushing and hypotension. Next is isoproterenol. It is a beta 1 and beta 2 stimulator. It is rarely used in emergency. It is mostly used in refractory bradycardia, AV block, and refractory torsades. However, it is contraindicated in patients with angina, pre-existing ventricular arrhythmias, tachyarrhythmias, or digoxin toxicity. The side effects are hypotension, PVC, tachycardia, ventricular arrhythmia, dyspnea, and pulmonary edema. So because of so many side effects, we do not use in emergency. Next is digoxin. It acts via blocking the sodium potassium ATPase channel. It also causes direct suppression of the AV node, leading to increased refractory period and reduced conduction velocity. Digoxin has a very low therapeutic range, 0.5 to 2 nanogram per ml, and toxicity develops at more than 2 nanogram per ml. Adenosine IV initial dose should be reduced to 3 mg in heart transplant patients and patients taking dipyridamole or carbamazepine, and when administered via central line. If the patient is taking theophylline or caffeine, you need to directly give 12 mg. What are the indications of digoxin? It is indicated for rate control in AF with CHF. So if a person has atrial fibrillation with heart failure with reduced ejection fraction, only then you are going to use digoxin. It is contraindicated in ventricular arrhythmia, WPW, acute MI, beriberi, hypokalemia, sinus node disease, AV block, and renal impairment. How do we give it? It is given 0.25 mg IV push with repeat dosing to a maximum of 1.5 mg over 24 hours, followed by an oral maintenance. What are the adverse effects of digoxin? They are generally GI side effects, including nausea, vomiting, and diarrhea. Other rarer effects occur that may include gynecomastia, skin rash, eosinophilia, thrombocytopenia, and it can cause sinus bradycardia, AV nodal block, and ventricular arrhythmias. It leads to yellow vision and mental status changes, delirium, hyperkalemia. So digoxin is a cause of hyperkalemia, but hypokalemia causes digoxin toxicity. Next chapter, pharmacology of vasopressors and inotropes. Vasopressors should be preserved for conditions when there is tissue hyperperfusion despite adequate volume resuscitation. So even after the patient having euvolemia, there is hypotension, you will use vasopressors, because most vasopressors have proarrhythmic potential. Most vasopressors have proarrhythmic potential and they exert their effects on both the heart and the vessels. Some agents also have inotropic properties and are used to improve cardiac output, particularly in patients with low EF and cardiogenic shock. If your patient, the cumulative vasopressor dose is actually very close to the patient mortality. A person in NORAD 5 is less likely to die than a person on NORAD 12. Ideally, vasopressors should be given via a central line. If you do not have a central line, take a line above the antecubital fossa, likely in EJV. If you have injected phentolamine locally using a fine needle and there is a sudden vasoconstriction and localized tissue necrosis, you can apply nitroglycerin ointment rapidly to reduce the tissue loss. Here is a summary of common vasopressors, their doses, effects, and contraindications. First is dopamine. There is hemodynamic support. We use 2 to 20 microgram per kg per minute. It increases your heart rate, BP, cardiac output, and systemic vascular resistance. Contraindications are if your patient has reaction to sulfa drugs, pheochromocytoma, uncorrected tachyarrhythmias, and VF. Next is epinephrine, our wonder drug. Its dose in asystole or pulseless VT or VF is 1 mg IV or intraosseous every 3 to 5 minutes until ROSC, or 2 to 2.5 mg via endotracheal tube every 3 to 5 minutes. You need to dilute the endotracheal dose in 5 to 10 ml NS. So you can give ET dose about 2.5 to 3 times of the IV dose. So the drugs that are administered via the endotracheal route can be remembered by the mnemonic NAVEL, 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 naloxone, atropine, vasopressin, epinephrine and lidocaine. So naloxone, atropine, vasopressin, epinephrine and lidocaine. Other drug that can also be used is diazepam for seizure control. But your NAVEL are primary: naloxone, atropine, vasopressin, epinephrine and lidocaine. If you are using epinephrine for bradycardia, use 2 to 10 microgram per minute. You can use a similar or lower dose in shock, septic shock. And if the patient has hypotension after intubation or hypotension due to sedation, you can give a 5 to 20 microgram bolus every 2 to 5 minutes as indicated. So 5 to 20 microgram bolus can be given after shock due to sedation or intubation. If the patient has anaphylaxis, you can give 0.3 to 0.5 mg IM by autoinjector, or you can give IV infusion 100 microgram stat and then 1 microgram per minute or something. In NORAD, you are going to use 8 to 12 microgram per minute. Titrate to a desired response to a maintenance of 2 to 4 microgram per minute. Phenylephrine, you will use 100 to 180 microgram per minute or 0.5 microgram per kg per minute. If there is hypotension after intubation or sedation, you will give an IV bolus of 40 to 100 microgram over and repeat every 2 to 5 minutes SOS. So hypotension after intubation or sedation, you are going to use phenylephrine 40 to 100 microgram bolus. Phenylephrine is a direct selective alpha-1 agonist, while phentolamine is a competitive non-selective alpha antagonist. Okay. It reduces systemic vascular resistance, causing vasodilation, lowers the BP. So they are basically anti of each other, phenylephrine and phentolamine. Vasopressin dose is 0.01 to 0.04 unit per minute. Angiotensin 2 is very expensive. It is used in septic shock. Initial dose is 10 to 20 nanogram per kg per minute, and then we can titrate. Next is dobutamine, 2 to 20 microgram per kg per minute. ACLS में immediately after cardiac arrest, you will give dobutamine 5 to 10 microgram per kg per minute. Milrinone, it is used in congestive heart failure, acute bridge to definitive treatment. Loading dose is 50 microgram per kg, then maintenance of 0.3 to 0.7 microgram per kg per minute. Now, what are the contraindications of each vasopressor? Dopamine, as we knew, it will not be used. It is contraindicated in hypersensitivity to sulfites, pheochromocytoma, uncorrected tachyarrhythmias, and VF. Epinephrine has no absolute contraindication. Norepinephrine, it is not used in hypotension from hypovolemia. Phenylephrine, it is not used in severe hypertension and VT. Vasopressin is not used in hypersensitivity to vasopressin or chlorbutanol. Angiotensin II has no absolute contraindications. Dobutamine is not used in hypertrophic cardiomyopathy with outflow obstruction. So in any case with outflow obstruction like aortic stenosis or HOCM, we will not use dobutamine, it is contraindicated. Milrinone is contraindication is hypersensitivity to milrinone. Next we will talk something about bolus dose administration of vasopressors. It is mostly used during surgeries and after intubation, as we know that all the induction agents and the sedatives, muscle relaxants, they cause fall in BP. So push dose vasopressors like phenylephrine and epinephrine has been used. Mostly phenylephrine is used, but epinephrine may also be used when we also want to increase the heart rate of the patient. Dopamine has side effects of chest pain, hypotension in low doses, hypertension in high doses, and ectopic beats, palpitation, VPCs, tissue ischemia. So it is not used. Dopamine is metabolized by renal, hepatic and plasma. Its half-life is very low, just 2 minutes. Epinephrine is hepatically metabolized. Its half-life is less than 5 minutes. Onset is 1 minute and half-life is 5 minutes. Norepinephrine is metabolized via monoamine oxidase MAO and catechol O-methyl transferase COMT. So NORAD is metabolized by MAO and COMT. It is excreted in urine. Half-life is 2 minutes. Phenylephrine is cleared in liver via oxidative deamination and glucuronidation, excreted in urine. Half-life is 5 minutes. Vasopressin is metabolized by liver and kidneys, excreted in urine. Half-life is 10 to 20 minutes. And angiotensin II, it is rarely used now. Half-life is less than 1 minute. Onset is within 5 minutes with infusion duration up to 3 hours. So angiotensin II is expensive, but it works very good and for longer duration. Next are inotropes. It contains our dobutamine and milrinone. Dobutamine is a synthetic dopamine analog with potent inotropic and mild vasodilatory and chronotropic effects. It stimulates alpha and beta receptors, beta 1 more than beta 2 more than alpha 1. Beta 1 is maximum, then beta 2, then alpha 1, resulting in increased contractility and heart rate. It is indicated for short-term management of patients with acute cardiac decompensation, particularly to increase the cardiac output. It can also be used in patients with persistent hypoperfusion despite adequate fluid resuscitation. You can use dobutamine with NORAD since dobutamine leads to hypotension, somewhat dilation, so NORAD will cater it. Adverse effects include hypertension, tachycardia, headache, angina and hypokalemia. Milrinone is used for short-term management of acute decompensated heart failure. It is also an inotrope with vasodilator properties, inodilator, that inhibits phosphodiesterase type 3, resulting in inhibition of CAMP breakdown in myocardium and smooth muscle cell, increase cyclic adenosine AMP, increase CAMP levels in the heart, increasing cardiac contractility. So milrinone basically inhibits the CAMP breakdown, so increase CAMP levels in the myocardium and increase contractility. So dobutamine inhibits the phosphodiesterase 3 thus decreasing camp breakdown and increasing the cyclic AMP camp levels, thus increasing cardiac contraction. Its side effects are ventricular and SVT, arrhythmias, hypotension, angina, and headache. What are the dopamine pharmacokinetics? It is metabolized hepatically, excreted in urine, half-life is 2 minutes. In milrinone, its half-life is very high, 2.3 to 2.4 hours, and duration of action is 5 to 15 minutes. Onset is 5 to 15 minutes, half-life is 2.4 hours. Next is levosimedan. It is a calcium sensitizer in cardiac muscle. It increases cardiac contractility by binding to troponin C in a calcium dependent manner, so increasing calcium sensitization. So it reduces vascular smooth muscle and increases cardiac contractility. It is also an inodilator, just like dobutamine, milrinone, and levosimedan. It is not currently FDA approved.